Assalamualaikum and a very good morning to everyone. Since we are doing the nasopharyngeal swab, and the reason why we have to do the swab in the nasopharyngeal because from the research that has been done on COVID patients, we have found out that the highest viral load is in the nasopharynx and secondly in the oropharynx. So of course we have to target the area that have the most number of virus to get a significant result and to avoid false positive. Okay, so since the area that is involved is the nose and also the nasopharynx, I'm just going to introduce to you where exactly are the areas. And 1 second. Cannot. Okay, enter. Right click
and next.
I see. Okay, right click and next. All right. Okay, so these are a diagram on the nose and also our pharynges. Pharynx are divided into three sub units. One is the nasopharynx. So as you can see, this is the nasal cavity, and nasopharynx is located at the posterior part of the nasal cavity, bounded by the base of skull superiorly, and then inferiorly is the soft palate. Okay, that is the area of nasopharynx, and sometimes we can have adenoid at this area here, especially in children. At the lateral wall of the nasopharynx, we have the eustachian tube opening, and eustachian tube is connected to the ear. Yeah, from the soft palate down to the around the level of base of tongue is the oropharynx, and then we have laryngopharynx or hypopharynx, which are made up of three subsets. Okay, so this is our area of concern, which is the nasopharynx. Hence, to reach this area, we have to go through from the nostril all the way along the floor of the nose to reach the nasopharynx. Okay. This is a diagram of the lateral wall of the nasal of the nose. Yeah, so we have this area here, which is called vestibule. This can be seen from outside. It contains the vibrissae, the hair, and then it contains skin. And then posterior to that is an area that is covered by mucosa, and we will see three structures at the lateral wall, which are called turbinates. This is the inferior turbinate, this is the middle turbinate, and this is the superior turbinate. And if we are looking at the nose from the front, you will be able to see the anterior surface of the inferior turbinate. And inferior turbinate is in close contact with the floor of nose over here. Okay, so anything or any abnormality in the inferior turbinates or in the vestibule or in the septum can hinder or can cause the process of taking the swab slightly challenging. Yeah. And from the front, each nostril is divided by a nasal septum. So this is how the turbinate looks like from a diagram from the frontal view. Okay, this is the inferior turbinate, middle turbinate, superior turbinate, and the septum. So with the concern when we are going to do a nasal swab for patient is the inferior turbinate and also the nasal septum here. And this is the opening of the nostril. Okay, so some of the anatomical abnormality that can be found in the nose that can cause problem when we want to do the swab. The commonest is deviated nasal septum and large inferior turbinate. Sometimes when patient has grade 4 polyps. Grade 4 polyps are polyps that extend down to the floor of the nose, and sometimes we can have septal spur. Okay, so I will show you the pictures of these structures. Okay, as you can see, some patient has nasal deviation or deformity. So in this patient here, this is a normal ala of the nose. Ala is this part here, the soft part of the nose there. So you can see the opening of the nostril fairly symmetrical. Well, fairly symmetrical on both sides. There are openings, but sometimes they can have a collapse of ala over here, like this one. because probably the nose is deviated to one side. So there's a deformity of the nose, a crooked nose. So this can cause one side of the nostril to be slightly narrower than the other. Okay, this is what deviated nasal septum looks like in the diagram. The septum, very rarely that you can have a straight septum in a human being. So you can have some kind of a deviation, whether it is minimal or it's causing any obstruction to the nasal passages. Okay, so this is how the deviated nasal septum look like. This is deviation to the left. So as you can see, the septum is actually in very close contact with the inferior turbinate. So this passageway is very small on that side. Oh, sorry. Right click. So this is an endoscopic view of a nostril. Endoscopic means we put in the scope and this is what we see. Okay, so this is the septum. How do you know whether this is a septum or turbinate? Septum runs from the roof of the nose down all the way to the floor, and there is a deviation here. Okay, as opposed to this structure over here, this is the inferior turbinate and this is the middle turbinate. Okay, so of course, if you can see a deviation anteriorly when you're looking at someone's nose, you should be avoiding that side, because we know that there will be a narrow passage and it will hurt the patient if, let's say, our swab is in contact with the structures. Okay, as opposed to this nasal septum over here, okay, there are more room. This is an enlarged inferior turbinate, but this septum has no deviation. So we can see all the way posteriorly to the nasopharynx. It's a bit dark here, but trust me, you are actually this one has quite a big space for the swab to go in. Okay. As for this case, there is a deviation of the nasal septum, and there is also an enlarged turbinate. And can you appreciate the difference between these two passageway here? You have a big room here, but there's no room over here. Okay, so it will be harder and more painful to do a swab on this nose as compared to this nose. Similarly, this one has obstruction as well. So deviated nasal septum and enlarged inferior turbinate can be a problem during nasal swabbing. So some other abnormality that you can see. Okay, this is another enlarged inferior turbinate, where from the basal view, when I say basal view, you are looking at the patient's nose from below. So prior to swabbing, it's helpful if we can actually have a look into the patient's nose from below, so you can see any obvious abnormality in the nose. Okay, so there's an enlarged turbinate as well, and slight deviation of the nasal septum over here. Another view. So of course, there's no two noses that are similar. Some nose, you can't see the deviation from anteriorly. So the point when you are doing any swabbing is to be gentle, and then you have to know the direction of how do you want to go into the nose. Okay, this is another abnormality, a deviated nasal septum with a spur. Spur is this sharpened structure of the nasal cartilage, nasal septum cartilage, and usually it will be in contact with the lateral wall, with the inferior turbinate or middle turbinate. This is another picture of septal spur, this sharp part there. Okay. So of course, as you can see, there's a very small room underneath the septal spur for your swab to go in. Okay. This is another diagram showing what you can see when you are looking into the patient's nose using this speculum here. This procedure is called anterior rhinoscopy. So anterior rhinoscopy is very helpful for all doctors to learn how to do. So basically, we inserted this speculum to bypass the area that has hair, and you will be able to see the inferior turbinate and middle turbinate. If you remember the first diagram just now, the turbinates runs from anterior to posterior. So when we do anterior rhinoscopy, we'll be able to see halfway posteriorly. So anything, for example, if you have a large polyps, you will be able to see already if you do anterior rhinoscopy. Yeah. So this is a diagram showing enlarged inferior turbinate. So from a normal one to a moderate enlargement, this is very much hypertrophied, and this causes total obstruction of the nasal cavity because of a huge turbinate there. Okay. This is a picture of nasal polyp. So this nasal polyp there are 4 grades of nasal polyps. So the first grade, of course, it stay at the lateral wall near the middle meatus, which is lateral to the middle turbinate. The grade 4, grade 3, they goes beyond the middle turbinate. So it's hanging up to the floor of the nasal cavity. So of course this one can cause obstruction, and if let's say you go through a polyp, you can cause epistaxis for the patient. Okay, this is another abnormality in the patient. Anterior caudal dislocation means the nasal septum in a normal person should sit behind this structure here. This structure, the skin is called columella. So supposedly the nasal septum cartilage should sit behind the columella, but in some patient it deviates out like this, so it causes obstruction on that particular side of the nose. Okay, I will just go back to the first diagram. Okay, this diagram here. As you can see, the orientation of the floor of nose here, this patient is sitting in a neutral position like this, and as you can see, the nasopharynx is here at the posterior part of your nose. And usually when we want to put in a swab, we are following the floor of nose here. So it's almost 90 degree. Yeah, the orientation or the angle where you insert the nasal swab should be 90 degree to the floor of nose. And you can feel as you're going, you are against something. So you just follow the floor of nose until you hit a resistance, which is the posterior wall of the nasopharynx. Then you can take the swab there. Okay, I think that's all from me. Thank you.
I have a question. So you say you have to put the nose, follow the floor of the nose until you hit a resistance. Then that's why the nasal polyp should be. But how to know if what we are hitting is not something abnormal, like a spur or like a deviation or a polyp?
Right. The other day when we were in the clinic, we have tried to measure 2 adults. The distance, how long do you have to go in to reach the nasopharynx? So the distance is roughly around 8 to 9 centimeter. So if let's say you go into a nostril and you got stuck at 2 centimeter or 3 centimeter, you know that you are not at the nasopharynx yet. Or if let's say the direction is slightly skewed, if let's say the patient is looking up and then you are going straight, you can hit this part here. Yeah, the posterior wall slightly above your nasopharynx. So if the other day we tried to do this experiment, this part here, if patient is looking up and you put in your swab and you hit this posterior part of your nose, it is around 5 to 6 centimeter. So to reach the nasopharynx, it has to be around 8 to 9 centimeter in an adult. Okay. Yeah, of course in children we cannot predict because children has different age, right? So from infancy to an adolescent, of course the measurement is different.
So as you say, we have to ensure that the position that you are pointing at is the same or same alignment to the top of the nose.
Yeah.
So if the patient is looking up, we have to go
parallel to the floor of nose. Yeah.
Like this, and then we go straight.
Yes. So if let's say the patient is tilting up their head, it is hard for us to assume where is the floor of nose. So I think what would be helpful is asking the patient to be in neutral position. So you know it's 90 degree. So this neutral position. If let's say they are tilting, you don't know how much they are tilting. So you can only guess how much you want to tilt the swab. But if they are in neutral position, then you go 90 degree. And I think that is a good a guideline or a good guide on how you will put in the swab into the nose.
So usually we see in television that the patient is up and the swabber is like taking from a slanted. That is not really very advisable.
It can be done, but of course it's slightly hard for the performer to actually gauge where is the nasopharynx really. It works. I've seen it been done multiple times. They do get their swab, but as I said, you don't know whether actually you're hitting the nasopharynx or you're hitting somewhere else. But of course you can get the viral load also in the nasal cavity. It's just that the highest concentration is in the nasopharynx. So we want to avoid false negative or false positive per se. So of course you want to get to the right place. So the guideline or the guidance is you have to go all the way perpendicular to the floor of the nose until you reach the nasopharynx, which is in an adult around 8 to 9 centimeter. Okay, this is what we measured in our clinic. But of course, there must be variation. The procedure shouldn't be too painful for patient. It's not comfortable, but then it shouldn't be causing a severe pain for the patient. But of course, if there is any obstruction, if you are hitting the septum of, or if we are hitting the inferior turbinates, it will cause some sting sensation and some pain for the patient. So we have to be very gentle while doing it. Okay.
So the indication to refer to ENT to do the swab would be like a difficult procedure, or medication resistance.
Yeah, I suppose if you see one side is already obstructed and you attempt the other side, if let's say there is a problem with the other side, then we can refer to ENT because we can have the help of the scope to do the swab. But if let's say the other side is not a problem, there's only obstruction on one side, then you can proceed. Of course, it would be problematic for patients to go from one clinic to another, right? So, but then I think for the benefit of patients, how do I say? Patients punya convenient. Of course, you have to have a look into the nose first. At least ask them to tilt up their head, look into the nose, so shine some light, look into their nose. Any obvious obstruction, then you don't go into that particular nostril. Try the other one. But if you can't see anything, if the deviation is at the posterior part, then there's nothing that you can do about it. I'm sure you can still reach nasopharynx, but then of course with a little bit of pain on the patient side. Yeah.
And some complications, it's pain now, of course, for the patient, and maybe it is really traumatic, epistaxis.
So if let's say epistaxis happen, pain usually doesn't linger for a long time, just during the procedure itself. If epistaxis happen in your patient, what you need the patient to do is something that we call Trotter's method. So you ask them to lean down, to lean forward. The reason why we want them to lean forward is if let's say they're bleeding trickled back to the throat, we don't want them to swallow the blood. This will cause stomach irritation, and then sometimes they can just vomit out the blood again. So lean forward. Any blood that comes into the oropharynx, into the oral cavity, just ask them to spit out. So you give them the yellow bin or the yellow plastic or any bin that you can have in your center, and then ask them to pinch the ala, soft part of the nose. Okay, pinch, don't let go. So it has to be a consistent pressure over the soft part of the nose, the ala of the nose. So like this. Okay, in this position, give them a bag of ice that they can put in their glabella, in between their just the upper part of the nasal bridge. So around the glabella and the nasion here. Okay, so this ice here, ask them to either gargle ice water or put in a small ice inside the mouth and push it against their palate. So in this position, they must be breathing through their mouth. Continue doing this for 10 minutes. If let's say on your reassessment after 10 minutes, the epistaxis is still a lot, so you have to send them to the emergency department and call ENT. Yes.
That's about it. Any last tips for us when you take the swab?
Okay. Last tips, I suppose the swabber or the performer has to really protect yourself, because anything that goes into the nose can cause irritation, and most of the time patient will sneeze. Either they sneeze and then you cannot really control the sneeze. So when they sneeze, of course you have a lot of spray of droplets from the patient. So the person who's doing the swab has to be in full PPE. Yes, and then position of patients, of course. So sometimes you are in a place where you are in that cubicle where you put in your hand. We call it combat here in our center. So probably you won't be able to be in 90 degree with the patient, with the patient's nostril. So that's when you have to really gauge the angle of how you want to go into the patient's nostril along the nasal floor. If you are in a place where you can position the patient properly, then you can do the 90 degree neutral position one. For children, most of the time you need help from other people to hold the child. So a parent can be holding the patient facing forward. So the parent's leg need to lock the child leg. Okay, you have to cross and lock the child leg. And then the parent has to hold both of their hands and hug them tightly. And then another person will need to hold the patient's head and then fix towards the parent's chest. So their head is fixed like that. So no lateral movement, no front to back movement. Then you perform in neutral position. So I find that very helpful because we do a lot of nasal procedure for patient children like that. And then have to really tell the parents that they have to really hold the child so that this can be done swiftly. If not, if they struggle, then they start to bleed, and then the child is traumatized, and probably it will fail. Okay, I think that's all.
Okay, thank you very much.
Welcome.
Miss Intan.